back to Daisy 2020, our last session talking about central vein obstruction. Now I would like to introduce you our chair, Dr. Jackie Ho from Singapore, Dr. Zhang Jianhua from Taiwan. As for our commentators, Dr. Liu Yingzuo from Taiwan, Dr. Ahmad Rafizi Haritz from Malaysia, Dr. Edward Choke from Singapore.
Hello everyone, welcome to the last session. This session we are talking about the central vein occlusion disease. I'm Dr. Liu, come from Taiwan. And Dr. Zhang is online now.
Yes,
let me introduce the chair, Dr. Zhang, please.
Hi everybody, and now you can see that I'm in different place because I have mission in my hospital. So now I just went back to my hospital in the morning, and I'm very happy I have time to join the section in the afternoon. I just very enjoy the discussion today. And this section, we are going to talk about the central vein stenosis and how can we use different methods to deal with this problem. And I'm very happy to see Dr. Liu and Jackie, we chair this section together. Jackie, do you have anything to say?
No, I think actually, although this is the last section, but I think this is one of the very controversial and very important section. So I'm really looking forward to all the great talks. So okay. Shall we proceed to the first talk?
Yeah.
Okay, now let us introduce the first speaker.
For our first speaker, let's welcome Dr. She Kang from China. His topic is operation techniques and single-center follow-up result of chest wall arteriovenous graft.
Dear experts and professors, good afternoon. This is She Kang. I'm from the Department of Vascular and Non-Vascular Surgery of Peking University First Hospital. I'm very pleased to join this meeting. The topic of my presentation is operation techniques and single-center follow-up result of chest wall arteriovenous graft. As you already know, the arteriovenous graft for hemodialysis can be implanted in many parts of this body. Today I'm sharing about a relatively rare form of arteriovenous graft called chest wall arteriovenous graft, referred to as CWAVG. My presentation will include these four parts. First, anatomy of chest wall arteriovenous graft. Second, indications and contradictions for CWAVG. Third, establishment of the looped CWAVG. And the last, single-center follow-up result of CWAVG in our hospital. For procedures such as hemodialysis access, the most important thing is to dissociate an artery and a vein. The target vessels of the chest wall arteriovenous graft is the axillary artery and the axillary vein. As we all know, the subclavian vein artery crosses the first costal and continues as the axillary artery. From the lateral margin of the first costal region, the subclavian vein artery passes diagonally through the axillary region and enters the arm at the lower margin of the teres major, which is renamed the branchial artery. The pectoralis minor muscle divides the axillary artery into three segments. The proximal of the muscle is the first segment, the posterior of the muscle is the second segment, and the distal of the muscle is the third segment. The axillary has 3 6-man branches, as the picture shows, with 2 branches per segment. The axillary vein extends from the branchial vein at the lower margin of teres major and passes over the lateral margin of the first costal margin into the subclavian vein. Sometimes it can be a double vein. The axillary vein has many variations and many branches of communications. It receives the corresponding branch veins of the axillary artery. The syphilic vein is located above the pectoralis minor muscles. and is inserted into the axillary vein near the subclavian vein. The anatomy of the subclavian fossa also requires special attention to the branchial flexus. The branchial flexus nerve is mainly composed of the anterior ramus of the 5th to 8th cervical nerve and the anterior ramus of the 4th thoracic nerve. The fibers of these 5 roots of the branchial flexus were first sensorized into the upper, middle, and lower trunks, and the medial, lateral, and posterior bundles were formed around the axillary artery by these 3 trunks. The medial nerve originates from the medial and lateral bundles and climbs the axillary artery. The ulnar nerve originates from the median bundle and travels between the axillary artery and vein. The radial nerve originates from the posterior bundle and behind the axillary artery. The target area was the second segment of the axillary artery. The main branches of this part was the pectoral coronary artery and the lateral pectoral artery. The optimal location of anastomosis is on the artery between these 2 branches. The axillary vein is generally located medial to the axillary artery, and the branchial flexus is first lateral to the axillary artery and then around the artery. The nerves surrounding the artery need special protection during the operation. So, when we can perform the chest wall arteriovenous graft and when we can't. We first introduce the indications for chest wall arteriovenous graft. The procedure is suitable for several conditions. The first is the vascular condition of the upper extremity is very poor, so the upper extremity hemodialysis axis cannot be established. The second is the vascular resource of the upper extremity hemodialysis axis are exhausted. The third is the venous outflow of upper arm arteriovenous graft cannot be repaired. As for the contradictions, the absolute contradictions, including other contradictions for arteriovenous graft surgery, such as severe cardiopulmonary insufficiency, systemic or local infection. The second one is the inflow tract from the subclavian artery to the axillary artery is severely narrowed or occluded. The third is the outflow tract, that is the axillary vein, is severely narrowed or occluded. The relative contradictions, including unable to tolerate the general anesthesia, or the central vein from the branchiocephalic vein to the splenial vena cava is severely narrowed or occluded. Here it is seen that the occluded central vein is not the absolute contradiction for the chest wall arteriovenous graft, and we'll do an example of that later in the speech. The chest wall arteriovenous graft actually involves a variety of surgical procedures. The basic 2 methods is the looped chest wall arteriovenous graft and the linear chest wall arteriovenous graft. The left picture shows the arteriovenous graft with loop configuration from the ipsilateral axillary artery to the axillary vein, where the linear means the arteriovenous graft with crossover configuration from the axillary artery to the axillary or subclavian vein, such as a necklace. Other derivative surgical methods, including the GOC sharp upper arm arteriovenous graft, implanting the graft from the branchial artery to the ipsilateral subclavian vein, the body wall arteriovenous graft implanting from the common femoral artery to the ipsilateral axillary or subclavian vein, or from the axillary artery to the ipsilateral femoral vein. The chest wall artery to artery graft, implanting the graft with loop configuration from ipsilateral subclavian artery to the axillary artery. The chest wall arteriovenous graft has many advantages. Being the highest position AVG in the upper extremity means it is very suitable for patients with vascular access exhausted in the arm. In clinic use, chest wall pain is not very sensitive, so it is easy to puncture for nurse. Compared with the lower limb AVG, the risk of infection and steel blood syndrome was significantly reduced. Compared with the neck AVG, the risk of facial swelling and the intracranial hypertension decreased significantly. Compared with a cardio-irregular access, it has lower difficulty and intraoperative trauma as well as lower risk of infection and mortality. Among all kinds of chest wall AVG, looped chest wall AVG and the GOC sharp upper arm AVG has a more comprehensive advantage. Early on, we did more chest wall AVG directly, while recently we did more J-sharp upper arm AVG, because the latter has a longer cumulative patency time. The chest wall arteriovenous graft also has several disadvantages. Although this operation can be done under local anesthesia, regional anesthesia, and other methods, our experience shows that the surgical process is still very dependent on general anesthesia. Intraoperative neuroprotection is relatively difficult, and after dialysis puncture, the patient needs to compress to stop the bleeding by himself. The incidence of high flow rate of dialysis access increased and may cause heart failure to worsen. It may also lead to subclavian vein artery still blood syndrome with symptoms of cerebral ischemia. The management of thrombotic complication relies heavily under DSA guidance. Using ultrasound detection is difficult. Okay, the next part I will show how to establish the classic looped chest wall arteriovenous graft. The patient in supine position under general anesthesia will usually elevate the shoulder of the surgical side and abduct the upper lip at 55 degrees. Because this is an artificial vascular surgery, prophylactic antibiotic must be used. The infraclavicle incision starts 2 cm lateral to the costoclavicle joint and extended towards to the deltopectoral groove for about 8 cm, forming a 35 degrees angle with the clavicle. In the abduction of the upper lip, the cephalic vein joins into the axillary vein from above. Divide along the clearance of the pectoralis major and expose the pectoralis minor, and then blunt separate the dorsal of the pectoralis minor and lift all the muscles. We clamp the pectoralis minor muscle on both sides, cut off the muscle layered by electric coagulation, and suture ligation for hemostasis. Disable electric life after this step to protect the branchial flexus. Next, cut open the axillary vessel shells. Separate the axillary vein and the second segment of the axillary artery. During the exposure of the axillary artery, the thoracic acromion artery and the lateral thoracic artery should be protected. The axillary artery is guarded superiorly by the branchial flexus and inferiorly and slightly anteriorly by the axillary vein. Dissociation both of the artery and vein enough length for block. This picture shows the relationship between the cephalic vein and the axillary vein, and complicate dissociation of the axillary artery and the axillary vein. Then we do small incision at the apex of the loop avoiding the nipple area. Establish a low subcutaneous tunnel to implant the graft. Usually we use 6 mm by 40 cm graft. After hybridization, we trim the graft and perform the end-to-side anastomosis of the graft and the axillary vessels, and then remove blocking and propulsion trail after the anastomosis is completed. If the trail is good, we do antagonism of the heparin. The last, place joint tube and close the incision. Please pay attention to the picture in the lower right corner. This shows we implant a chest wall arteriovenous graft for a patient with occluded superior vena cava, and the primary patency time of the graft is about 2 years. That tells us if the collateral circulation compensates well, we can still consider operating the chest wall arteriovenous graft. The last part is the single center follow-up results of chest wall arteriovenous graft in our hospital. Because of the difficulty of the surgery, there have been very few large studies of the chest wall arteriovenous graft. Most studies involve dozens of the cases, and the communicate patency rate was about 50 to 80% 2 years after operation. Here is a follow-up results of the chest wall arteriovenous graft in our center, from January 2014 to June 2015. a total of 12 cases, including 3 males and 9 females. The average age was 63.6 years. The mean age of hemodialysis was 38.4 months. The mean number of the hemodialysis axis failure before the chest wall arteriovenous graft implanted is 4.2 times, from 1 to 14 times. The follow-up time was 30 to 48 months, with an average of 35.4 months. All cases were looped chest wall arteriovenous graft, 8 on the left and 4 on the right. 2 patients died, one with massive gastrointestinal bleeding and one with heart failure. The primary patency rate and cumulative patency rate after operation shows here. The cumulative patency rate of 2 years was 33.3%. I have to say that due to the limitation of various subjective and objective conditions, many patients do not choose surgical repair when they lose the function of the chest wall arteriovenous graft, but directly switch to other methods of dialysis. So the cumulative patency rate is not much higher than the primary patency rate. 8 patients with chest wall arteriovenous graft failure, 6 has thrombosis, 1 has aroma, and 1 has steel blood syndrome. Among them, 4 patients underwent tourniquet cuff catheter, 3 underwent arteriovenous graft on other lips, and 1 underwent peritoneal dialysis. Here we show the patient who underwent hybrid surgery to treat thrombosis in the chest wall arteriovenous graft. The patient is in supine position under local anesthesia. First, with incision near the anastomosis of the vein side. The graft isolated and divided. After hyperization, we insert the guide wire and the Shields tube to do the central vein angiography to find the thrombosis and the stenosis. The stenosis is just beside the anastomosis of the axillary vein, and we do the volume dilation by high-pressure volume catheter. Then we use Fogarty catheter to do embolectomy from 2 directions. After confirm the backward flow of blood in vein and the posterior bleeding in artery, we suture the incision on graft. Here are some methods to improve the long-term patency rate of the chest wall arteriovenous graft. First, during the operation, the anastomosis should be pruned to obtain better local hemodynamic structure. As the picture shows, the beveled anastomosis allows for an intentional slight redentancy of the graft to avoid mechanical obstruction of the vessels due to the shoulder motion. Second, the application of the heparin drug-coated graft may help to improve the post-operative patency rate. The third one is using an anastomosis clip instead of traditional sutures, like the picture shows. The effect of this non-penetrating vascular wall anastomosis technique used for dialysis access on improving post-operative patency rate has been proved by many studies. In the use phase, the antithrombotic drugs, rope bladder puncture, and modulator regularly all help to reduce the occurrence of loss function events. Finally, based on the evidence from recent studies, when the anastomotic site repeated stenosis, we may consider that the application of the coated stent. To summarize, the chest wall arteriovenous graft is an important supplementary operation for upper extremity dialysis access. The chest wall arteriovenous graft is usually located in the axillary artery and the axillary vein. The axillary artery, axillary vein, and the branchial flexes are closely related, so the branchial flexes should be protected carefully during the procedure. The short-term patency rate of the chest wall arteriovenous graft is ideal, where the long-term patency rate still needs to be improved by various means. That's all. Thank you for your attention.
Okay, thank you, Dr. Xue's presentation. We will discuss later. Now, let us introduce the Dr. Ong from Taiwan. He will share his experience about the hero graft. Please.
Thank you, Chair. Okay, let me start. Chair, the panelists, and all the audience, hello, good afternoon. I'm Wen Shixian and from Taiwan. And today I'll talk about the hero graft in my own experience and the Taiwan experience. Okay, let me introduce myself first. I trained in the Taipei Veteran General Hospital and served in my current hospital, the Lancet International Hospital, since 2014. And I stayed in that hospital for maybe 5 to 6 years. And this is our hospital, and located in the southern of the Taoyuan. Taoyuan is nearby Taipei. And my hospital is around 15 minutes to the Taoyuan airport. And this is our team. We have 3 vascular surgeons and 2 pumpists. We do the cardiac surgery, aortic surgery, and most of all the peripheral surgery. And this is our equipment. We use the ultrasound, and we use the CM, the simple CM, can do the angiography, and we can do hero in this local regional hospital. We don't need a fancy hybrid room to do the hero, because hero is a straightforward procedure. These days, in these 5 years, we perform around 8,000 procedure and operation, and some cardiac surgery, some aortic surgery, and some TIVA and EVA. But most of all, we perform the hemodialysis assays, creation, and the maintenance. As you know, according to the data of USRDS 2018 annual data report, Taiwan always the first ranking, both the incidence rates and the prevalence of the treated ESRD. So we got many hemodialysis patients here in Taiwan. And in the city, the Taoyuan city, where my hospital located, I calculate around maybe 8,000 to 9,000 population of hemodialysis patients. And we have 14, including 8 CVS team and 6 cath lab to management for the maintenance of these hemodialysis assays. Yes, and in around these 5 years, we do around 4,000 operation and procedure for the maintenance of the HD assays, just like thrombectomy, CDT and PTA, and some surgical revision. Okay, and among these operations, the most difficult is the central venous steno occlusion. You can see the patient, the left side have the profound collateral veins. That's the symbol of the central vein stenosis. And sometimes the arm swelling and the face swelling develop. And this is the typical we performed for the central vein stenosis patient before the hero graft introduced in Taiwan. Yes, we use guidewire to pass through the lesion, the total occlusion lesion, like the left side, and use a small balloon to balloon up for the predilatation. And then we use a larger balloon and then implant the stent graft. I use cover stent. Yes, and the left is the preoperative, and the right side is the final shot. I think the final shot is pretty good, but maybe a couple of months later, couple of years later, each stenosis develop, or sometimes instant stenosis develop. And the other issue is the catheter dependence. Sometimes we encounter catheter dependence. Sometimes the hemodialysis unit call you the catheter occlusion, and you got to help them. And their chief complaint is that you can push the normal saline into the catheter, but it's hard to withdraw the catheter of the blood or the normal saline because the fibrin sheath. Yes, a lot of inflammation cells cover around the catheter, so the catheter is not functioning well, and the dialysis clearance is very poor. So, it's the value of the hero graft to resolve this, to solve these two problems. One is the central vein stenosis occlusion, and the other one is the catheter dependence. Yeah, and when you encounter the failing AV fistula or AV graft due to central venous stenosis, and when you encounter the catheter dependent patients, you solve these two problems. You can use the HERO graft. The HERO graft is the hemodialysis reliable outflow, and it is the only fully subcutaneous AV access solution to maintain the long-term access for hemodialysis patients with central venous stenosis. And you can see the product overview. Got an arterial graft component with 6 millimeter ID and a venous outflow component we call VOC, have a 5 millimeter ID and 6.3 OD. And it is a bulky device with a 19 French, and we need a 20 French peel away sheath. And between them, we have a titanium connector to join these two components together. Yes, and the indication for HERO graft is as follows. The first, the catheter-dependent patient, and maybe exhausted all the upper arm, the upper limb assays, and maybe the second one is the poor veins outflow, yeah, and maybe it needs repeat PTA, repeat reintervention, and the third one is the central vein stenosis and occlusion problem. And the last one is the clearance is low. The KD over V below 1.4 is the indication. And what is the contraindication? Because we still have to anemosis the graft into the artery. So the too small artery is not good. So suggest the brachial artery or target artery is better is over than 3 millimeter. And then you have to prepare the central venous vessel to let your VOC into the RA. And the not mentioned here, maybe patient should not have to poor cardiac function, the LV ejection fraction much better over than 20, and the systemic blood pressure is better over than 100 millimeter mercury. And patients should not have a topical or systemic infection. And when you perform this procedure, you have two skills. One is open surgical skill to anemosis the artery. The other one, you have an endovascular skill to pass through the total occlusion lesion. But if you don't have in the other one, you can act a good friend, just like a cardiovascular surgeon, cooperate with the intervention radiologist, get together to perform this procedure. Okay, and first, you can see the procedure overview. First, we put the VOC into the RA. Yeah, second, we made a cut at the subclavicle area and at the deltopectoral groove and the titanium connector join arterial graft part and the VOC together here. And the third, we make an anemosis to the target artery. Yeah. And after you finish the HERO graft, maybe you have to wait maybe 4 to 6 weeks after the wound heals, then you can start puncture. Between these, you can use a temporary catheter for the bridging. And besides the de novo HERO graft implantation, it also have another option. You can do it as a salvage procedure for the central vein stenosis, but the AV fistula puncture site or AV graft puncture site as well. You can use the fistula salvage or AV graft salvage procedure. And that is the outcome, clinical outcome. You can see the bacteremia rate, the infection rate is lower than the catheter, and the adequacy of the dialysis, the clearance is better than the catheter, and the cumulative patency rate is better than catheter, and the reintervention rate is better than the catheter. And the HERO graft data is equal to the graft previous literature. So when you compare the HERO graft to the catheter, around the infection rate, the clearance, and the patency rate is much better than the catheter. So if the patient have a catheter-dependent failing fistula or have central vein stenosis, have a poor clearance, you can think about this product. Okay, let me introduce my first cases of using the HERO graft. She's a 56 years old male, and she got hypertension, diabetes, hyperlipidemia, end-stage renal disease. And he received his hemodialysis for over decades, and exhausted bilateral upper lip AV fistula, AV graft. No axial event can be anemosis. Sure, and that chest wall AV graft might be a consider, but I'm not a well-skilled surgeon, so I choose an easy way. I choose the hero graft, and she got have a catheter dependent for over 3 years, and the KD over V is 1.15. Yes, you can see this is the previous permanent cast. Yes, and after we withdraw the permanent cast, we can see the fibrin sheath. You can see the stenosis of the brachial cephalic band till to the SVC. So before insert the VOC, we used a balloon to open up the vessel. After open up the vessel, we exchanged the permanent cast and inserted the VOC. But during this procedure, be aware of the bulky profile of the peel-away sheath because it's 20 French, it's really bulky, yes, and the VOC is 19 French. So you have to be very careful to push the VOC into the RA. Then after pushing into the VOC, you peel away the sheath and let the VOC in the RN and clamp it. And then you can make a tunnel to insert the graft. You can connect together first, or you can make the arterial anemosis first. That's okay, that's fine, yeah. So after we finish the procedure, it's really straightforward. You can see the final picture of the hero graft, and the tip of the graft is in RA, and it functions well. You can see the patient's wounds healing well maybe 4 weeks later, and we start to puncture. It's just like a normal upper limb brachial axillary AV graft. Yeah, and after 6 weeks, we start to puncture for hemodialysis, and the KT over V is quite well. It's 1.8 compared to previous 1.15. Yes, and 15 months later, the patient encountered her first hero graft occlusion, and then we declot for her. You can see that the declot is really simple. We use endovascular way. We take the picture and we declot the thrombus. Use the double lumen Fogati, and you can see we start at 20:35 and finish at 20:49. It takes maybe 14 minutes to finish this procedure. And why? Because we don't have to do PTA for the V junction for the central vein stenosis. Yeah, thanks for Edward. I'm not here. Thanks for as our proctor for our first case. Yes, and now Taiwan is available for the superhero. Superhero, you can use the selective graft, just like flexing or the AQCO. Yeah, it has two parts. The first part is the VOC. The second part is the adapter. And you can choose your own, like your early cadulation graft, just like flexing or the AQCO or the standard wall graft, the Impra, Gore-Tex, anyway. And you can use the adapter. But if you use the standard wall graft, you have to use a suppositio, the left one. That before you adapt the graft into the adapter, you have used this graft expander for 3 times to enlarge the graft, then have a better connection between the adapter and the graft. So how about the hero graft using in Taiwan now? Yeah. I have 3 cases experience. 2 is the hero graft and 1 is the superhero. Just finished this Friday. And in Taiwan, the first case implantation is in the 2018, the summer, yes. And the total implant case number of hero graft in Taiwan is 43. And it is performed by the 16 institutes and 19 doctors, including 18 vascular surgeon and 1 intervention radiologist. And this is the case number. The hero graft coming to Taiwan in 2018, and the superhero coming to Taiwan, and the first implantation is the December of last year. Okay, and among these 43 cases, the indication, the most of all, the 50% is the catheter dependent. And the 11 cases is the central venous stenosis with repeat PTA. And the 3 cases is the central venous stenosis with instant stenosis. And the 5 case is the tough case, is the central vein complete total occlusion. Yeah. And 40 cases, we use general anesthesia, and 3 cases use local anesthesia. Yeah. And the procedure time, we do not do 2 stage, we do 1 stage. And the average, the procedure time is less than 100 minutes. And in the CTO case, it's much harder. So it takes maybe sometimes up to 4 hours to pass through the CTO lesion. Yes. And the hero graft case is 39, and the superhero case is 4. And 3 use the flexing graft, and 1 use the propellant graft. And the VOC route, 33 case via the right side, and 10 cases via the left side. And especially 1 case is done by the medical center doctor. He advanced the VOC via the axillary vein route. Yes, and according to the arterial inflow, most cases are mostly to the brachial artery, and 1 case is the doctor would like to reduce the possibility of the Steele syndrome, so he administers to the axial artery. And 7 cases is not a de novo hero graft implantation, it's for the AV fistula, AV graft salvage. Yes, and the flexing case and the salvage case can be punctured immediately. So among these 43 cases have 4 mortality. 1 is cardiac events, and 3 is non-cardiac events. And all of these cases is non-surgical related. And to get local infection, and we use topical antibiotic ointments and resolve this. And 1 have a grade 3 Steele syndrome and need revision. And 1 old patient refused puncture. So he used a catheter, go back to use the catheter. So do not use the hero graft. And 6 perform this year, the first season, so still not using yet. So there are still 33 functioning hero graft and underusing now. Yeah. Okay, about the patency performance, in these 33 cases, which is underusing, we exclude the mortality case and exclude the not underusing case. The 6 months primary patency rate is around 94, and the 1 year primary patency rate is around 83. Yes, and the later implants in the last year, the 4th season, the Q4, the 14 cases do not have a reintervention reported yet. Yeah, and the current cumulative patency rate is 100%. And however, 7 cases need reintervention, and 5 cases need a reintervention after 1 year after implantation of the hero graft, and 2 cases need frequent reintervention, maybe need PTA every 2 months or need declot every 2 months. Yes. Next, I will show you the reason paper. Yeah, it's published in the JVIR this year. Yeah, it's the study from the Duke University Medical Center, and this patient cohort is the same as the previous hero graft patency study. And this study is a single center retrospective study for 10 years from 2006 to 2015. And the patient selection from the 192 patients who implant hero graft. But our focus is the patient that hemodialysis patient with arm swelling because of the ipsilateral central vein stenosis. They have divided the patient into 2 groups. The first group, the treatment strategy is the converted AV fistula to hero graft. The other one is use the stent deployment. Yeah, you can see that these 2 groups. The first group is the hero graft group, have 21 cases. And the second one is the stent group, have 27 cases. These 2 groups, the characteristic have no significant difference among the age, sex, and venous occlusion. Yeah, but in hero graft, maybe the multiple central segment of stenosis is noted. But however, The stent type in this study, most of them are bare stent, and only 20% are cover stent. Yeah, we can see the comparison. You can see the first one. You can see the primary and the primary outcome, the resolve of the arm swelling. There's no difference between these two groups. But maybe after 6 months later, previous significant arm swelling recurrence in the stent group, and the primary patency rate is lower in the stent group and higher in the hero group. And the secondary patency is also higher in the hero group. And the reintervention rate is also lower in the hero graft group. So you can see the curve of the primary patency between the hero graft and the stent, and the secondary patency between the hero and the stent. So the result is that between two groups, the stent and the hero graft, the relieving of the arm swelling were similar up to 3 months. But after 6 months, the stent group significantly have a higher recurrent swelling symptom, and the hero graft group have the higher primary and secondary patency rate and the lower reintervention rate. So my personal opinion, I think that hero graft is a really straightforward procedure, but it's very important to select the proper patient for the best benefit of this device. And I think, between two groups, the catheter-dependent patient is much easier to perform this procedure, and the central vein total occlusion patient is much harder. So the technique to close the CTO lesion is the key to finish this procedure. And always aware of that bulky PLOA sheath and VOC profile when you're advancing the device into RA to reduce the injury of the vessel. Then, because previous study is compare of the hero graft and most of the bare stent, so I think the further study may be needed to compare about the hero graft and the cover stent. Yeah, that's my talk. Thank you.
Okay, thank you, Dr. Wang's presentation. Now, let us introduce the next speaker, Dr. Wang from China.
For our next speaker, let's welcome Dr. Wang Yufei from China. His topic is central vein intervention, perspective from nephrologist.
Dear Chairman, commentators, and all the friends online, good afternoon. It's my great honor to be here and talk about central vein intervention, the perspectives from nephrologist. I'm Yufei Wang from Zhengzhou, China. From all these pictures, we can see central vein obstruction is not rare in our dialysis patients. It's the most serious complication with irreversible and recurrent character. When that symptoms occur, I think it depends on the balance between blood flow back to right atrium and the collateral veins compensation. When the balance is broken, we can see many symptoms like venous hypertension and access dysfunction. The reasons of CVO can be divided into two parts. We can see central vein catheters is the most common reason of intravascular device, and we should be aware of the extrinsic compression of vein, like venous thoracic outlet syndrome and the compression of the left innominate vein. As for central vein intervention, my understanding includes protective interventions and rescue interventions. At a relatively early stage, with no stenosis or mild stenosis, protective interventions are palliative and more important. We should avoid or reduce catheters, such as shorten the indwelling time of catheters. We can use self-sealing graft for special patients, salvage immature fistula timely, and avoid subclavian catheters or left-sided catheters. Secondly, we should optimize permanent access. such as avoid fistula creation at the same side of catheter, and pay attention to high flow access. Besides, we should have lifetime VA plan, especially for patients with long life expectancy. At the advanced stage, the rescue interventions are passive and costly. The first thing we should know is that only the patients with symptoms should be treated. Without a symptom, there's no need to intervene. The second thing, we should do adequate assessment before intervention, including clinical abnormalities and diagnostic imaging properly used. We know DSC is a golden standard, but it has limitations. DSC provides us a two-dimensional image, and it can be affected by breathing, so CTA and IVUS can be good supplements. The third thing, there are so many options we can choose, like endovascular therapy, surgical repair, flow reduction, or hybrid procedure, and we should choose the optimal one. From this table, we can see it's the nephrologist who always accompany patients from CKD stage 1 to stage 5 and even hemodialysis. So nephrologist is one of the most important part in VA plan. And nephrologists did well in VA management. We can see from this graph, after the nephrologist's participation, the AVF ratio in USA elevated obviously. So I believe nephrologists will do well in central vein protection as well, and there are a lot of work we can do. This is Professor Zhang Suoliu, the director of our hospital, giving lecture in last year's annual meeting of Nephrology Committee of Chinese Medical Association, and he emphasized the role and duty of nephrologists in dialysis vascular access. And today we can see nephrologists in mainland China have great passion for vascular access. Like this year's DASI online conference, I think there may be a large amount of nephrologists in mainland China are watching. They are eager to learn new theories and technical skills to treat patients. So I say we are not just nephrologists. We also provide rescue interventions for CVO. Usually, endovascular therapy is the first choice for CVO, and acute thrombus will also exist on the basis of CVO. At this time, we should consider thrombolysis using medicine or mechanical instruments, like these patients with right internal jugular vein TDC and left arm swelling for 1 week. The angiography should left innominated vein thrombus and severe stenosis of the superior vena cava, and we can see the extensive azygos vein. After thrombolysis, the thrombus and symptoms disappeared. And another patient with left arm AVF, after removal of the right internal jugular vein TDC, arm swelling and neck face also swelling. Angiography showed severe stenosis of superior vena cava. We can see obvious azygos vein. After dilatation using 14 mm balloon, we can see more collaterals existed. What happened? Firstly, we don't know. After angiography using the catheter, we can see it's the acute thrombus. So after thrombolysis, we get a fluent superior vena cava. PTA is often used in CVO with good short-term patency, but the shortcoming is recurrent, and frequent intervention is required. Here we have no experience about DCB. But the covered stent seems good for long-term pregnancy. In the past 2 years, we treated 27 patients using 29 covered stents, and stent type includes wire bond, Fluency Plus, and excluder. Technical success was 100%. We followed up from 2 to 18.5 months. The indications of covered stent includes field annuloplasty with elastic recoil, a residual stenosis more than 50%, some patients with extrinsic compression lesion. A stenosis recurred more than twice within 3 months, or occlusive lesions, and also venous. This is a lesion distribution, and we can see occlusion is the most common indication. Like these patients, firstly, we field cross the occlusive lesion using traditional guide wire and catheter techniques. So we tried sharp recanalization using transept needle, and for guided catheter as guiding, use capture device, get the V18 wire. After dilatation, we put an excluder stent with good result, and we followed up 8.5 months so far. No symptom recurs. And this is the data from our center. The total number of patients was 27. At 6 months, there were 19 patients followed up. Target lesion primary patency was 84%, and access primary patency was 78%. Cyst primary patency 100%. And at 12 months, there were only 7 patients. The primary patency was 71%. Assist primary patency was 100%. It seems good results. At the time of 18 months, there were only 2 patients followed up with primary patency 50%, assisted primary patency 100%. I know time is limited. We will continue to follow up. Edge stenosis is the main reason for reintervention. Like this case, it is first case we use covered stent. With left innominate vein occlusion, after PTA, there were residual stenosis, and we put a stent graft. 12 months later, we found severe stenosis of the distal edge, and then received PTA. After that, we got a fluent outflow. So far, we followed up for 18.5 months. Received PTA twice. It's an acceptable result. And there's only 1 patient with stent thrombosis, like this one, with right arm AVF. Angiography showed subclavian vein occlusion. After PTA, we put a stent graft, and it seems good results. But 2 months later, the stent occluded, and then after PTA and thrombolysis, we get a relatively acceptable result. Then we continued to follow up. 2 months later, the CTA showed that there was severe compression of the stent at the costoclavicular conjunction site. This case told us, before making intervention, any cord assessment should be done. As for surgical repair of CVO, I think flow reduction is a minimally invasive procedure. We don't do something like surgical bypass or something else. For these patients, we can see the right innominate vein occlusion and many collaterals. After PTA, there's still many collaterals. Then we try to do the flow reduction. We conduct a Miller procedure. After the procedure, we found the collateral disappeared and the patient's blood flow decreased from 2.5 liter to 1.2 liter per minute. As it followed up for 7 months so far, there was no recurrence of symptoms. And sometimes we return to AVF again, like this patient with TDC, frequently infection and dysfunction. We re-evaluate the central vein. We can see the obvious azygos vein. And the patient is small size. So we created a new AVF of the forearm. After the maturation, we removed the TDC. After follow-up for 24 months, the patient received 3 times PTA. Now the AVF functions well with normal blood flow and venous pressure. I think the key points includes extensive venous collaterals and avoid high flow. In the end, for central vein intervention, I think there are so many things nephrologists can do and should do. For protective interventions, we should estimate GFR decline rate accurately, avoid or reduce catheters, and let more nephrologists and patients recognize central vein obstruction to reduce central vein complications. And for rescue interventions, we should choose suitable plan and cost-effective plan to improve central vein obstruction symptoms and prognosis. Above all, the ultimate goal is to help patients spend less money and get better results. And in summary, protective interventions is the most important thing. Adequate assessment is the beginning of success of rescue interventions. The current standard has shown better patency than other options nowadays, and large-scale studies are needed to find the best solution, and we should choose a suitable option for individualized treatment. So thank you for listening.
Okay, thank you, Dr. Wang. Let us know his experience about central vein intervention. Now, let us introduce our latest speaker, our good friend, Dr. Chen Weihua. He will let us know about the stent, bare metal stent in the treatment of central vein stenosis.
Okay, thank you, Dr. Liu, for the kind introduction. I'm the last speaker of this final session, so please stay with me for the final minutes, and we can, we can turn off our app after this talk. So we know that the bare metal stent, a lot of evidence show that it's not really the best option for central vein stenosis. So today I'm going to share some of my view for the our algorithm using bare metal stent to treat this central vein stenosis. I have nothing to disclose. So we treat a patient with symptoms. So these are the symptoms that we usually met with patients suffer from central vein stenosis that we needed to treat them. So we have heard from the previous speaker about the some problems that cause central vein stenosis, like central vein line, like extrinsic compression of the adjacent structure, coagulopathy, pacemaker lead. And for me, I think the problem is that a lot of dynamic compression by LT arch and bony structure, which I learned from my IVUS experience. So the main algorithm to treat it is to do the prevention. So never try to place catheter ipsilateral to the side you create the access, and use less central vein catheter from the subclavian vein, and also avoid prolonged placement of the central vein catheter, and also treat the patient if the patient is symptomatic. Don't treat any lesion that's not symptomatic. And I think our goal to try to preserve try to treat the central veins, we try to preserve the access. So it's not that we like to put stent. It's just that we try to preserve the access, because if you don't do that, a lot of symptomatic patients, they might need to, give up the access. So we learn from a lot of evidence that cover stent do much better than the bare metal stent. And the bare metal stent actually has the same effect with the plain balloon angioplasty. So this is data that that the PTA doesn't do well. So 30% patency at 12 months only. So currently the recommendation is that we treat the patient with symptom, and also the patient should have residual stenosis after PTA more than 30%, and also the lesion recur within 3 months of angioplasty. So the patient need to be the recurrent patient, and there is a residual stenosis after you do the plain balloon angioplasty. But the problem is that the bare metal stent don't have a very good result in the long run compared to PTA. And we start to use stent graft to treat this part of the patient, because the stent graft has a lot of benefits, including the better radial force, and including there's a barrier for the ingrowth of the intima that we think before. And if we do have any other stent that share the same characteristic as the stent graft, can we use that? Can we use a venous stent, which has a good radial force, even much better radial force than the stent graft? So this is data that we learned from the literature before, that actually the stent graft at this position, 1 year primary patency is 67%, and the assist primary patency is 80%. Currently that we use IVUS in most of the case that we do with the central vein intervention. And before we use stent graft, especially sometimes we needed this endural limb is actually apart from the EVAR, which we use the limb as the stent we pick, because the size is bigger, and we believe that the radial force is better. And also we can modify the stent on the table, because the length sometimes vary among the lesions. So you can't use, sometimes you need to modify the stent. You don't want to cover too much. And this is the size that we measure from the IVUS. That actually for the subclavian vein from the IVUS, the normal size is range from 14 to 16. And the innominate vein is 16 to 22, and right innominate 12 to 16. So this is the area that we estimate for a normal patient. So this is the study we done previously. After we do 82 cases using the stent, that we try to look at the data, and then we found that most of the case we use is stent graft Viabond, and some we use the AAA limb for this cohort patient. The mean follow-up time is 600 days, and the mean age is 69 years old. So most of the place that we need to put the central vein stent is the subclavian vein, is 48%. And the innominate vein, actually, there's 43% of patients needed to put the stent. And we seldom put the stent in the SVC. And for the ISR cases, actually, there's 32% of the cases are ISR cases. So this is the initial data that I show you, that actually the self-expandable stent graft actually has a quite good extracerebral primary patency. And for the target lesion primary patency, as you can see here, at 1 year, it's more than 80%. So which is better than the data that I presented to you before. It's a 60% from other literature. So if you can use the bigger size of this stent graft, then you might get a better result. And the patency can last until 2 years with 80% of target lesion primary patency. And also, if we use IVUS in these kind of cases, we found that the diameter of the stent that we use will be bigger compared to the case that we didn't use IVUS. So we believe that IVUS had added patency to this procedure. So this is the data that we just look at the self-external stent graft. As you can see here, the target lesion primary patency is 84% at 1 year, 80% at 2 years. And if we use IVUS, we have even better patency, as you can see here. So it's for us that we believe that because we can more accurately measure the size of the stent, then we can have a much better result. So if we already have a much better stent graft result over here compared to the previous literature, why should we choose to other stent? Because stent graft still got a lot of problem. One problem is that when you cover the stenotic part, sometimes you have to cover some outflow, some inflow. So sometimes we need to sacrifice the interjugular vein, and not all the patient is asymptomatic if you cover those inflow. And also some stenosis lesion is very long. So we have some problem with the lesion which from innominate vein to subclavian vein, sometimes you need very long stent. So is it possible that we use just bare stent and don't have to cover everything? And also one big problem with the stent graft is that we still have some problem over the costal clavicular junction. We still have compressed viabond or compressed fluency over the area, because that area sometimes will collapse the stent graft even if you put 2 stent graft there. So this is another problem. So a lot of surgeons, they think that the surgery is more appropriate for this part of the central vein. And also the profile of the stent graft is bigger. So it's not really a big problem to us because we are vascular surgeon, but still I think if we can have a smaller profile of stent, it will be much better. So this is the stent that we usually use. Actually, the first one is the wall stent. So they have a different configuration. So the last one is actually the Venovo, the second generation venous stent. It's a laser cutting stent. And this is the picture that we get. If you put a wall stent there, as you can see here, that it's just compressed and it's very difficult to do other intervention. And we can also see another picture here is using the balloon expandable stent. And you can see here, the stent looks open, but actually the stent is fully compressed. So actually the stent is already occluded. So this are the problem with the first generation venous stent or other bare stent. So how about this venous stent? So we use this second generation venous stent over the iliac vein initially, in my experience. I think that a lot of benefit for this stent because it has a very good flexibility, high radial force, and high compression resistant force. As you can see the data here, as you can see, like compare this stent to other stent like Zilver Vena. Actually, they have a much, or the wall stent, they have a much better radial resistive force. As you can see, what I highlight here, and they have a similar characteristic with the sinus obliquus or other second generation stent. So this is one of the benefits of using this stent. And this is also the study from, you can see here the Venovo have a much better quarter resistant force compared to the Optimed sinus venous. Even it's much better compared to the Cook Zilver Vena. And also the stent flexibility is very important here. And it comes with larger size available now in Taiwan is 20, and the longest length available is 10 centimeters. But actually they have a longer one, but it's not available now in Taiwan, but I hope that in the future it's available. So we know that from the calculation that 19% increase in the radius will double the volume flow rate. So the size is very important when you do this central vein stenting. So this is the case that I show you. First, there's a case that before we used the balloon assembled stent here for the innominate vein stenosis occlusion. And then we found that actually the patient present with the compress of the stent H by the costal clavicular junction. So in this case, we try to use the second generation Venovo to salvage. As you can see here, after we do this Venovo stenting, we follow the patient, and it seems the Venovo do quite well. And even the distal part of the stent become a flare configuration, which is really quite crush resistance. So, sorry. Okay, so this is 1 year. After we put that Venovo stent, you can see here is the configuration is still doing well. The patient is asymptomatic, is doing well. So the case 2 here, initially the patient present with venous hypertension. We did not treat the central vein. We just treat the outflow of the cephalic arch. And then 6 months later, the patient actually developed venous hypertension, become the swelling of the leg upper extremity. And we used the IVUS, and we found that actually the venogram shows compression of the innominate vein, but actually it's very, very much compression. It's more than 80% of stenosis. So we need to treat that part. So this is the calculation that we measured all the way the innominate vein, and then we figure out optimal size for this part. We use a 16 times 60 millimeters Venovo for here. And then 11 months later, I don't know whether you can see the slide properly, but I actually can see the configuration of the stent is very good. It's not compressed, it's very good. So this is another case that we have a pacemaker incidentally placed on its lateral part, and the patient suffer from swelling because of the axis and the same side. And then you see we use a Venovo for this area. And then we found that 6 months later, the patient is doing well, and the configuration is still good. And we do notice some very special thing about using the Venovo, like in this case. You can see at the 3 months, I'm a bit worried when I put a stent here, because looking at the stroke, I'm afraid the stroke might get compressed or might get fractured. But actually, I think it's because of the motion of the patient. So if you see at the 6 months, actually the configuration of the stent stroke seems okay, and 9 months is still doing well. So I think the Venovo is really cross resistance when you use at this coastal clavicle junction. So I think it's very different from the other bare metal stent that we used before that was used in the artery. So we only did 14 lesions, 12 patients until now. So we use IVUS guide for all the procedures, and male and female is 3 to 9, and the mean age is 65 years old. And most of the access is on the left side, and we have a more arm AV graft compared to AV fistula in this patient. And then the lesion mostly is a stenotic lesion, and the de novo lesion, most of the case is de novo lesion. So this is the position of the stent that we put. So we have subclavian vein, right subclavian vein, and also innominate vein. Innominate vein is not so compression, so I think the most difficult part may be the subclavian vein. If the stent can survive the subclavian vein, then I think it's appropriate as used as a stent for the central vein stent. So the mean follow-up is until now is 213 days, and then we follow the patient with X-ray to check the configuration of the stent, and also we use the 6 month and 12 month angiogram to confirm. So up to now, our mean follow-up is 200 days, and then the target lesion primary patency at 6 months is 100% patent, and the access circuit primary patency at 6 months is 78.6%. This is the data, the survival curve that I show as we mentioned before. And I think the Venovo currently at 6 months, the data is quite encouraging. So finally, conclusion of my talk, the summary, I think we already have a lot of experience with stent graft. Actually, the stent graft can be done well if you use the IVUS guide. It will have a quite promising target lesion primary patency. So, but for the second generation venous stent, I think it has can overcome some of the problem with the stent graft. And initially, our target lesion primary patency at 6 months is 100%, and the access circuit primary patency is 78%. I think the target lesion primary patency matters with the sizing and also adequate seating. And I think the Achilles tendon for central vein stenting is always a coastal clavicle junction. And in this part, I think from our very limited, very small stats group of this using the Venovo stent population, we find that actually it's doing well at this area compared to the other stent in this coastal clavicle junction. So I think we have to follow up the patient for long enough, and then to watch whether this will prevail after 1 or 2 years follow-up. Okay, thank you for your attention.
Thank you, Dr. Chen, and thank you all speakers. Now, Chen, would you have any problem? Does any recommendation?
Thank you very much for all the excellent presentations. Now the section is open for comments and questions. Yes, Haris, yeah, nice having you here. Yeah, please state your comment or question. Dr. Harish? Can unmute Dr. Harish mic. Yep.
Can you see this? No, cannot. Four questions actually. To all the speakers just now, I think very good talk. The first one is about the chest wall AVG. Is there any concern for high output cardiac failure? Because I noticed there was one mortality from the series that was presented, and it was from heart failure, and there's a lot of shunting happening from initial part. So that's my first question. The second question is about the hero graph. Because I was told by my colleague here in Malaysia that the hero graph is not being sold anymore because it was pulled out from the market. So whether is it really true that it's been pulled out from the market worldwide, or is it still available to be used? So that's my number 2 question. My number 3 question is for the nephrologist. Regarding the thrombolysis, when you have central venous thrombosis, do you do catheter-directed thrombolysis or systemic thrombolysis in these patients? And finally, for Jimmy, do you have any experience with a de novo stent at the cephalic arch stenosis? And as a surveillance after the de novo stenting, do you routinely do chest X-ray? I think that's all my questions. Hope all the speakers can give a good answer. Thank you.
Thank you, Dr. Harish. Yeah. So we go to the speakers. Who would like to respond first? Jimmy.
Maybe I respond first. Hello, Harish.
Hi, thanks.
Hello, yeah. Your question about the cephalic arch using the venous stent, right?
Yeah.
Yeah, I think it's a big problem because the venous stent now the least diameter is a 12 millimeter, and you know the cephalic arch is not as big as that a lot of cephalic arch is just 7 or 8. So in my daily practice, I don't routinely use in that area. So until now, I haven't had any experience using this second generation venous stent over the cephalic arch. But I do have one case using at the axillary vein. This patient presented with the axillary vein CTO, and then we do the initial angioplasty, but actually the flow is not very good. So we put a 14 millimeter, I think it's a 6 centimeter stent over the area. And actually the patient is also included in this series. And it seems the patency is quite good until now. So I don't have any experience now using this second generation venous stent over the cephalic arch.
How about the surveillance post-stenting? Do you really do the
the problem with the central vein stenting surveillance is we can't do echo, right? So for me, I don't like to do a lot of CT for this kind of patient. So currently, because this is off-label use for this, venous stent over this area, so currently we follow the patient with X-ray, because X-ray sometimes I think is very accurate. If you have any compression or any, this displacement, is very easy to detect. And I found that if the stent gets problem, you will first find it on the X-ray. So we routinely do X-ray now, because also for the study. So we also do venogram. So venogram was done like 6 months and 12 months for the patient. And some patient maybe they will have some problem with the access. So when we do the access in PTA angioplasty, we also survey the central vein. So this is how we follow the patient now.
Thank you. Maybe Dr. Wang Yufei, you would like to respond to Harish's question?
Okay, can you hear me?
Yes.
The first patients during the angiography, we found the thrombus in the left innominated vein and the severe stenosis of the superior vena cava. We choose an easy way to just thrombolysis using angiographic catheter and pump into the thrombosed site using urokinase. And after about 4 days, the thrombus disappeared and the patient's symptoms also disappeared. And after that, I followed up this patient about 1 year. 1 year later, he made the symptoms recurred, but he went to another hospital and then many procedures. And now I don't know what's his symptoms now. So, and the second patients during the PTA of the SVC, and we found the many collaterals existed. Firstly, we don't know what to do, and what happened, we don't know. And then we did angiography using a catheter, and we found that maybe it's the thrombus. Then we tried thrombolysis, and after that we can see affluent SVC. And thank you.
Okay, thank you, Yufei. I think what Yufei mentioned is they will infuse the urokinase directly into the thrombus area rather than a systemic urokinase. Yeah, and Dr. Wang, you would like to respond to the question from Dr. Harish?
Okay, thank you, Dr. Hedge, for your question. But can you repeat your question again? Can you repeat your question again, please?
Doctor, let me just check. Okay.
Yes,
sorry,
we can hear you.
Your talk was about chest wall. Is it chest wall?
Hero graph.
Yeah, sorry. No, because I was told by my colleague about the hero graph that is not available anymore in our market. Whether is it just in Malaysia or is it worldwide? I'm not sure. I was told that it's worldwide. So, but now you are presenting about this hero graph. So I'm not sure whether is it still available for us to use or not. And
Sure. I just performed the superhero this Friday.
So is it?
It means the superhero replaced the hero graph, or even the superhero is not available in Malaysia?
Yeah, so far superhero is not available yet.
Okay, I see. But I don't have any information that now superhero or hero graph is not available currently, because I just performed a superhero case just this Friday.
Okay.
2 days ago.
That answered my question. Thanks.
Okay.
May I also ask Dr. Wang, so among the experience, who are the patients that with hero that will have more frequent thrombosis and re-intervention? Is there any characteristic of the patients that maybe one can predict?
I think because if you put the proper position of the VOC, and because of no central venous stenosis occlusion problem, no V-junction problem, so the problem is the graft puncture site. So maybe the patient who have the risk factor, who's maybe just like have some inflammatory process, can deterioration of the graft, make the graft early degeneration. This kind of patient, or maybe the patient with hypotension, and maybe I think most of them are the poor hemostasis way by the patient. So I think we should take time to teach those patients how to hemostasis. Yeah, don't use the tonic, just use your hand. And sometimes some their way of the lifestyle. Yeah, I think is the most problem. Yeah.
Thank you. And John, can you maybe help Dr.
Our first speaker, Dr. Shi, he could not online with us, but he just texted the answer for us. And he said that, yes, there is possibility to cause hyper-output heart failure. So they will choose tapered graft, the 4 millimeter and the 7 millimeter tapered graft to avoid this complication. And they say they have 2 mortality cases. One patient died of pneumonia, and another patient died of GI bleeding. Yeah, not because of heart failure. Yeah.
Okay. Eddie. Yes, Dr. Edward Chok.
Yeah, hi, Jackie. And I was going to ask the same question as you, but you asked already. So I'm just going to add a comment here to James' excellent presentation. So the Taiwanese experience of 75% 12 months primary patency for the hero graft is extremely good. It's fantastic. And so you've shown us that patient selection is very important. So I just wanted to add on to that. Yeah, it's absolutely right. I absolutely agree. So patient selection is absolutely important. And we found that with better patient selection, our primary patency in Singapore has improved tremendously. My question then is to Jimmy's presentation. So the Taiwanese cardiovascular surgeons, you guys are the pioneers in showing us how to use covered stents for central vein occlusions. And now you've shown us with the new generation bare metal stents like Venovo, you can also similarly obtain excellent results. So can I ask you now, in your experience, how would you choose, let's say next week in a patient with central vein occlusion, what are you going to use, stent graft or bare metal stent?
Yeah, hi, thanks, Eddie. I think if for the innominate vein, the right side or the left side, I think both stent graft or this bare metal stent will do very good because there's not so tight compression there. But I think the case that we tend to choose with the this second generation venous stents, those cases that you might need to stent, across some place like, the junction with the internal jugular vein. So in this part of area, I tend to like to stent with the bare stent because I still don't like to, just fully cover everything. So this is one of my philosophy for choosing the stent. So, but if based on the data, actually because in my previous experience, I think coastal clavicle junction, actually, the stent graft doesn't really do very, very well there. So we still have problem with that area. So for that area now, I tend more to stent with this second generation venous stent because they have a much better this radial force or compression resistive force if compared to stent graft. So for that part of area, I more suggest that we do this second generation venous stent. But actually, for my data, there's only one case that have less than 1 year, the ISR problem. Actually, that's a very complex case. So for other cases, I found that this has no problem with that area. So currently, my belief, I think we can consider to use that over the coastal clavicle junction, if compared to the bare stent.
Thank you.
Dr. Harish? And then afterward, Yufei. Dr. Harish first.
Hello. Quick question to Jimmy. How about the SVC obstruction? Can you still put in the Venovo and then just gel the illuminate?
I think SVC is a very good place to put that. But you know, the problem is the sizing is very important there. So in order to not to have an incidental stent dislodgement, I think proper pre-dilatation and post-dilatation is very important there. So I think for me, because I haven't had any case in this series in the SVC, because it's not very common here in Taiwan. But I do think, with my previous experience with other stent graft, I do think it's a place that we can place stent if needed in that area, because the deployment system for this Venovo stent is very stable. So it doesn't jump, it doesn't have a lot of shortening during this deployment. So I think it's much safer compared to other product. If you choose this one, the deployment is very stable. So for me, I think if you need, you can try.
You don't have any problem jailing the innominate on the other side?
Oh, no. If you use the bear stent, you won't have the problem. If you use the bear stent, if you use the stent graft, actually I think it depends on the sizing, because the SVC, if you send something from the left innominate vein to the SVC, I don't think you will completely gel the SVC unless your SVC is already diseased, very small SVC. So I don't think normally you would gel that. So I think that's not the problem if you're afraid about gelling this place. Yeah.
Yes, let's take the last comment or question from Dr. Wang. Dr. Wang Yufei. Yeah.
Two questions. Sorry. The first one is what's the indication for re-intervention for stent graft post-stent graft implantation? As for me, some patients in my center, when we followed up the patients without symptom and with no obvious elevated venous pressure, but when we did angiography, the angiography showed severe stenosis at the stent edge, maybe more than 80%. But this case, if we should do the PTA, the patients, the follow up is very difficult. We call the back, and sometimes they always delay the follow up. So when this time at the 80% stenosis, we did the PTA. Maybe we shorten the intervention time. So it's a confusion question. It's my confusion. And the second question is how we can accurately choose the length of stent. We know the DSC can only tell us a two-dimensional image. When we measure the length on the DSC image, we can we get a 10 millimeter. We choose a 10 millimeter length stent, but the left innominate vein, it's tortuous. When we put the stent, maybe we cannot cover the distal edge. So if there is tricks to accurately evaluate the length we should choose. Thank you.
Jimmy and John and any other speakers, commentator would like to give your thoughts and opinion on these questions?
Yeah, I think if you see a patient have critical, just you mentioned 80% age stenosis of stent graft, I think you should do PTA for this patient, because if you don't do that, it will be totally occluded very soon. Yeah. And your second question, how to measure the length? You can use the pullback technique. You just mark the proximal part you want to stent, and then you pull back your catheter, and you can mark the catheter just outside the sheath, and you pull back to the distal part and just measure the length. Maybe the length will be shorter than actual, because you just mentioned that maybe this very tortuous, our guide wire will go the shortest the route, but it would be better just use your eyeball to measure the length.
Okay, thank you, Chair. Thank you, everybody. Thank you, all speakers. Thank you, all audience. Enjoy our last department. Now it's time. It's time up now. Thank you.
We have come to the end of Dialysis Access Synergy 2020. Before we really end the meeting, we would like to invite Dr. Ke give us a few words of closing.
Hi, everybody. Closing of DAISY 2020 in Taiwan is definitely not the end of DAISY meeting. The prosperous, fruitful discussion this year, I believe we will extend to future DAISY meetings as well. And with the threatening of the virus infection, within merely 3 weeks, we have successfully converted the meeting into a teleconference. I think this is not only the milestone of DAISY meeting, but also a milestone of all kinds of medical conference. So in the future, we believe that we will be stronger. Well, there is some numbers I want to announce to all of you. Within 3 days, we have completed 58 talks within 13 sessions by our 65 faculties from international. And all those talks, they add up to more than 22 hours of footage of live streaming. Actually, those content will be remain on the web and keep on contribution to all of us. I would like to announce proudly that within 3 days, I believe there will be more than 20,000 visits on the internet, and the numbers will accumulate because all of you can go back to the internet to see all the recaps. And so please tell your friend, in the future, if you want to get any recap of this meeting, please search for DAISY, D-A-S-Y, on the internet. You can go to YouTube, you can go to Facebook and see our links and see the recap again and again. So I want to express my sincere thanks to Society of Dialysis Access Specialists. Now I'm going to transfer the time. I'll ask Jackie Ho to say something, to make some closing remarks to all of us. Jackie, the time is yours.
Thank you very much. John asked me not to cry. I'm not so sure because I'm really, really moved and have to say deep appreciation to Paul and every of the organizing team and all the AV IT people. You can see there is a lot of setups and people there to support the meeting to make it very smooth, and the image, the audio are very clear. I know occasionally there are some hiccups in the internet, but I think this is already a very, very clear, very, very good live streaming of the whole meeting. And I have to say that the broadcast using both YouTube and WeChat is a huge success. So I think DAISY 2020, with all the threats of this pandemic, the nature closed the door, but there is a wide open window that will open to the world. So very, very moved and really appreciate all the faculties, companies that support us, and audience that join us and actively participate. So without the passion, without the dedication, it will never make DAISY 2020 a big event and successful. And I hope the educational value has spread out as far and as much as possible. So next slide, please. But anyway, I still think, of course, it's already a very, very major steps forward, but we will always have rooms to improve. So do put your comments, feedbacks. We will value all this information very much, and do contact us. And also, please, next slide, please. Join us. We are the society that we don't turn away any people that dedicated in dialysis access, and join us, and we will actually share information. We're a big family, and we hope the whole arena of dialysis access can progress and become much and much better. So with that, really thank you everyone, and see you next year. Before the transmission ends, I have to say, everyone please be vigilant, can slow down the work a little bit, and just keep yourself safe and keep yourself healthy. See you next year. Thank you.
Thank you, Jackie. Thank you all.